Opioid medications have long been a cornerstone for managing pain in patients undergoing surgery. Despite efforts to introduce non-opioid alternatives, opioids remain widely used, especially in the perioperative setting. In the United States, opioid overuse and abuse have become a significant public health concern, with thousands of overdose deaths reported annually. This situation has prompted clinicians and researchers to seek safer, more effective pain management strategies that minimize opioid reliance. As we explore the landscape of perioperative pain control, understanding the prevalence and risks of opioid use is essential for appreciating the need for alternative approaches. To address the opioid crisis, leading medical organizations now recommend multimodal pain management strategies. These approaches combine different types of medications and techniques to achieve effective pain relief while reducing opioid exposure. Enhanced recovery after surgery (ERAS) protocols exemplify this trend, prioritizing the use of non-opioid medications to minimize side effects like nausea and sedation. By integrating various analgesics, ERAS aims to improve patient recovery times and shorten hospital stays. This shift in practice highlights the ongoing search for safer, more balanced pain management solutions in surgical care. Among the non-opioid options, skeletal muscle relaxants have gained attention as potential adjuncts in perioperative pain management. These medications, commonly used for conditions like fibromyalgia and back pain, may help reduce pain and limit opioid consumption when used alongside traditional analgesics. However, muscle relaxants have diverse mechanisms of action and can cause side effects such as dizziness and sedation. Their role in surgical pain management is still being defined, but early evidence suggests they could be valuable additions to multimodal protocols, especially when tailored to individual patient needs. Recent literature review examined the efficacy and safety of muscle relaxants as adjunctive analgesics in the perioperative setting. The review focused on studies that included adult patients, monitored opioid consumption, and documented pain scores and adverse events. After a thorough search of major medical databases, only 3 studies met the strict inclusion criteria. These included 2 randomized controlled trials involving tizanidine and 1 retrospective cohort study with methacarbamol. The limited number of high-quality studies underscores the need for more research in this area, but the available data provide valuable insights. Tizanidine, a muscle relaxant with antihypertensive properties, was evaluated in 2 randomized controlled trials. In one study, a single oral dose of tizanidine given before laparoscopic cholecystectomy significantly reduced both opioid consumption and postoperative pain scores compared to placebo. Patients also experienced shorter recovery room stays, though some reported drowsiness as a side effect. Another trial found that tizanidine, when combined with a nerve block, lowered pain and opioid use after thyroid surgery without increasing adverse effects. These findings suggest tizanidine may be a valuable tool for perioperative pain management. Methacarbamol, another muscle relaxant, was studied in a retrospective cohort of orthopedic surgery patients. The combination of intravenous methacarbamol and acetaminophen led to a significant reduction in opioid use after hip and knee replacements. However, patients in the methacarbamol group reported higher pain scores, possibly due to differences in pain management protocols, such as the absence of patient-controlled analgesia. While the hospital stay was slightly shorter, the increased pain intensity raises questions about the balance between reducing opioid consumption and maintaining adequate pain control. While muscle relaxants show promise, their use requires careful consideration of safety and dosing. Tizanidine, for example, can lower blood pressure and should be monitored closely, especially in patients with cardiovascular risks. The timing of administration is also important, as the drug's peak effect and half-life influence its effectiveness during surgery. Methacarbamol has a similar short half-life, which may limit the need for multiple preoperative doses. Ultimately, the choice of muscle relaxant and dosing schedule should be individualized, taking into account the type of surgery and patient-specific factors. Despite encouraging results, the current evidence base for muscle relaxants in perioperative pain management is limited. Most studies focus on single preoperative doses, and there is little data on the use of other agents like metaxalone or cyclobenzaprine. Variability in study protocols and the use of additional analgesics can confound results. More rigorous clinical trials are needed to clarify the optimal agents, dosing strategies, and patient populations that would benefit most from muscle relaxant adjuncts. Expanding research in this area could help refine multimodal pain management and further reduce opioid reliance. Summary: muscle relaxants like tizanidine and methacarbamol have demonstrated potential to reduce opioid consumption in surgical patients, with tizanidine also lowering pain scores. However, safety, dosing, and patient selection remain critical considerations. As perioperative care teams strive to balance effective pain relief with opioid minimization, muscle relaxants may become valuable components of multimodal strategies. Continued research and individualized patient care will be key to optimizing outcomes and addressing the ongoing challenges of pain management in the surgical setting.